This first case Articles on the Go feature is titled Normalization of Deviance, Groupthink, Shortcuts and Workarounds in the Operating Room. Written by David Gomez, CRNA. As healthcare struggles to maintain accountability, safety, and outcomes related to surgery, it has started to embrace the long-standing military and aviation concepts of high reliability as it relates to organizational structure, training, and accountability. In short, this means they are being proactive instead of reactive. The concept of highly reliable organizations, or HROs, is defined as an organization that has succeeded in avoiding catastrophes in an environment where normal accidents can be expected due to risk factors and complexity. This statement is completely representative of operating room environments. These concepts were created due to many preventable accidents and catastrophes within the aviation and space industries. Normalization of deviance and groupthink behaviors greatly contributed to horrible loss of life and injuries, and, of course, tremendous financial liabilities for the aviation and space industries. Diane Vaughan's Normalization of Deviance definition from 1996 stated that social normalization of deviance means that people within the organization become so much accustomed to a deviation that they don't consider it as deviant, despite the fact that they far exceed their own rules for the elementary safety. This means that organizations get so accustomed to doing something they may get away with, knowing it could be done better, until all the right conditions align to create a serious sentinel event or injury. Normalization of deviance can lead to groupthink, where there's a natural human tendency to rationalize shortcuts under pressure, especially when nothing bad happens. The lack of bad outcomes can reinforce the rightness of trusting past success instead of objectively assessing risk. Many of the shortcuts and workarounds we embrace in the operating room when it comes to surgical positioning, for example, are just routine. Many of them we think are completely normal. Unfortunately, they are not normal. They are only indicative of the antiquated products and organizational methodologies that have failed to keep up with the rise of comorbidities like obesity, or for advanced surgical platforms that subject our patients to greater degrees of gravity-dependent and specialized positioning requirements needed for robotics and laparoscopic surgery. Products must be designed to facilitate highly reliable behaviors, not encourage them. So much focus is on patient safety, but little attention is paid to provider safety. They are symbiotic and must be balanced. For example, the impact of ergonomics on positioning processes for lithotomy required Trendelenburg procedures. Safe patient handling is designed to improve caregiver safety in positioning patients, yet we still rely on antiquated guidelines requiring staff to lift and move anesthetized patients with a bed sheet and then use it to tuck the arms. Most product designs just mimic outdated guidelines. Surgical table dimensions impact ergonomics, as staff is usually forced to move patients 7 to 14 inches on average for lithotomy positioning. Often, staff will put their patients in a lithotomy-ready position to save their backs, only to expect anesthesia to reach down several inches to manage the airway and intubate because they wish to position their patient in a lithotomy-ready position. Foam pads require maximum skin-to-pad contact for traction and stability, yet we cover up 40 to 80% of the effective surface area with a sheet. Positioning is also highly nuanced, especially in high BMI patients, so we add tape, towels, foam, gel, blankets, and plastic sleds as we try to create a solution. Again, we don't even bat an eye at the whole idea of this, and there usually isn't a hospital policy on highly reliable positioning processes. In short, there are improvements out there that strongly consider these processes and these challenges. They are designed to facilitate processes and behaviors needed to reduce ergonomic effort, variance, and safety risks for both patients and providers. We need to move past the workarounds and move toward highly reliable methods of positioning. Not only will this improve outcomes and protect our patients, it will protect providers as well. As always, thanks for listening to this episode of First Case Articles on the Go.